of the day. I am Dr. Shweta Bavari from Pharmacy Institute, Noida Institute of Engineering and Technology, Greater Noida. In this lecture, I will be covering the topic Pathophysiology of Hematological Diseases and Gastrointestinal Disease. As I already told in the previous lecture, that hematological diseases are the pathological conditions that primarily affect the blood or blood producing organs like red bone marrow. In the previous lecture we have already covered iron deficiency anemia, megaloblastic anemia, sickle cell anemia, thalassemia. So in this lecture we will be focusing on hemophilia and hereditary acquired anemia. So beginning with the hereditary acquired anemia. Hereditary acquired anemia is more specifically known as paroxysmal nocturnal hemoglobinuria. Paroxysmal means sudden occurrence and nocturnal generally in night. Hemoglobinuria means that there is excretion of hemoglobin in the urine. Okay. So it is a rare acquired disorder of the red cell membrane. Focus on the term red cell membrane. It occurs due to inactivating mutations in the PIGA gene on the X chromosome. When I use the term inactivating mutation, inactivating mutations are the mutations in which the gene is suppressed. It is inactivated. So it will no more be producing the product, the protein or the enzyme it is coding for. In this case, which particular gene has been inactivated? PIGA gene. So this PIGA gene codes for the enzyme PIGA, which stands for phosphatidyl and acetyl aminyl transferase subunit A, which we call PIGA, PIGA. So when this gene has been inactivated, there is an inactivation mutation, inactivating mutation. So when this gene is mutated, it doesn't, it stops the production of the enzyme PIGA. Okay. Now this enzyme PIGA, it plays a very important role in the protection of the cell membranes of RBCs, granulocytes, which are neutrophils, basophils and eosinophils, and platelets from the complement mediated attack. Now before I go any further, I would like to notify the complement system inside our body, apart from the T lymphocytes and B lymphocytes. The complement system is also a part of our body's defense system, the body's part of immune system basically. So these complements are made up of a large number of proteins, okay, and these proteins are synthesized in liver. So they work in cascade. These proteins are released from the liver and then they work in cascade, and when this complement system is activated, they basically attack certain type of cells. When they are activated against a particular type of cell, they will target it and destroy it. Alright. So I told you that this enzyme PIGA plays a very important role in protecting the membranes, the cell membranes of RBCs, granulocytes, neutrophils, basophils and eosinophils and platelets. Okay. Now when I told you in the paroxysmal nocturnal hemoglobinuria, what happens? There is inactivating mutation in the PIGA gene and there is deficiency of PIGA. Okay, so this enzyme is not being produced. So basically the membranes of the RBCs, granulocytes and platelets remain unprotected and they are now susceptible to the complement mediated cell lysis. Okay, so they are no more protected. They are susceptible to the complement mediated cells lysis. This means that the membranes of the RBCs are destructed and this results in hemolysis. And also when hemolysis occurs, large amount of hemoglobin is released into the circulation and ultimately excreted in urine, which also ultimately results in hemoglobinuria. So this is paroxysmal nocturnal hemoglobinuria. Apart from that, the patients who are suffering from this disease, paroxysmal nocturnal hemoglobinuria, they are also susceptible for various infections, for thromboembolism. How? Because I told you that the membranes of the granulocytes are also no more protected by PIGA. Okay. So when the membranes of the granulocytes are not protected, that means there will be destruction of neutrophils, basophils and eosinophils also. And these are the major players in preventing infection in the body. And thromboembolism, because when there are distortions in the membrane of the platelets, it can result in abnormal formation, abnormal clotting events or formation of platelet plugs, which can result in thrombus formation, the platelet plug formation or clot formation, and then this thrombus can dislodge from its site where it was originally formed and can start moving in the blood vessels, in the circulation. This is known as thromboembolism, and this can be fatal also, because again, when this clot which is floating in the blood, when it enters into a microcirculation in a very narrow capillary, it can block the blood supply to a particular cell or a tissue, which will again result in anemic condition. Why? Because there will be what? There will be oxygen deprivation in that particular area and can result in cell death in that particular area. That's thromboembolism. Now coming to the pathophysiology of hemophilia. Hemophilia is a hereditary clotting disorder associated with serious bleeding. Now if there will be any discrepancy in clotting, in the complete clotting cascade, or we call it coagulation cascade, if there is any defect in that clotting cascade, it can result in hemorrhagic condition. It can result in profuse bleeding. This hemophilia is basically an X-linked recessive trait, okay, and it is inherited basically. There are two clinically indistinguishable forms of hemophilia. Why we call indistinguishable? Because ultimately, if there is any defect, in the entire coagulation cascade, if there is defect with any of the clotting factors, ultimate result is going to be there will be no formation of the blood clot, there will be no formation of the fibrin threads, there will be no formation of the blood clots. That is why it is indistinguishable, because ultimate result is no formation of clot and there will be profuse bleeding, hemorrhagic conditions. So this symptom is common for any form of hemophilia. There are two principal types of hemophilia, hemophilia A, hemophilia B. In hemophilia A, basically it occurs due to the reduced activity of coagulation factor 8. The coagulation factor 8 is also known as anti-hemophilic factor A. In hemophilia B is caused by reduced activity of coagulation factor 9, which is also known as Christmas factor or anti-hemophilic factor B. Now I would like to show you where this coagulation factor is involved. As you can see, I have shown here the intrinsic pathway, general description of the intrinsic pathway, the extrinsic pathway and the common pathway of the clot formation. So these pathways ultimately lead to a common pathway, and then there is a production of thrombin from prothrombin. Okay, so there is a production of thrombin, which is the factor 2. This factor 2 that ultimately is involved in conversion of fibrinogen to fibrin threads. These fibrin threads which are formed then result in formation of a mesh of the fibrin threads that stick over the platelets and result in clot formation. Now if you can focus in the intrinsic pathway, factor 8 and factor 9 are very crucial components of the intrinsic pathway. Now imagine a scenario where these factor 8 and factor 9 are not working properly. When they are not working properly or they are not involved in this cascade, that means this coagulation cascade, this process of clotting will halt. It will stop then and there, and the intrinsic pathway will not enter into the common pathway, and there will be no formation of the fibrin threads and no clot formation. This is what happens in hemophilia basically. So regardless of the deficiency of either factor 8 or factor 9, the coagulation cascade remains incomplete. Failure of the conversion of fibrinogen to fibrin threads and hence failure of the formation of blood clot occurs. This results in easy bruising. There is easy bruising, means a minor cut will also result in profuse bleeding. Then massive hemorrhage after trauma. If the trauma is minor also, now the trauma was minor, the blood flow started, okay, the blood loss started, blood is coming out of the body, but there is no clot to stop it. So it can result in hemorrhagic conditions, there will be profuse bleeding, there is no clot to stop this loss of blood from the body. Then there can be spontaneous hemorrhagic conditions in places such as joints, these joints which are prone to friction. Okay, there is lot of abrasion, there is lot of friction in joints. So the joints where there is lot of friction, there can be spontaneous bleeding also, because there is no clotting factor, there is no fibrin thread to stop it. Okay, so these are the effects of hemophilia. The symptoms of hemophilia, they include repeated episodes of severe and prolonged bleeding at any site, even in the absence of trauma, recurrent bleeding into joints accompanied by severe pain in the joints basically. So these are the most common symptoms which can be seen in hemophilia. Moving ahead to the pathophysiology of gastrointestinal disease. When we talk about gastrointestinal disease, we are focusing on the diseases of the GIT, gastrointestinal. Gastric stands for stomach, intestinal, the intestine. Okay, and in this lecture, we will be focusing on peptic ulcer. So what basically are peptic ulcers? So ulcers are defined as breach in the mucosa of the gastrointestinal tract. In very simple terms, we can say there is erosion of the mucosal lining of the stomach and the intestine. If you can see in this image, the figure displayed here, that there are various layers in the stomach and the intestine, in the gastrointestinal tract. There are various layers. There is serous membrane, there is submucosa, there is longitudinal muscle layer, there is circular muscle layer, there is muscularis mucosa, there is submucosal plexus also. But the lumen, in the lumen you can see there is mucosal membrane. This mucosal membrane or mucosal lining is the protective lining that doesn't allow the acid to penetrate, the acid which is secreted in the stomach for digestion of the food. It cannot penetrate inside and corrode the layers of the stomach and the intestine beneath this mucosal membrane. The peptic ulcers are chronic lesions that occur in any portion of the gastrointestinal tract exposed to the action of the acidic gastric juice. The most common sites for ulcers are the stomach and the first portion of the duodenum, which connects with the stomach basically. The principal causes of peptic ulcer, the most important cause of peptic ulcer is basically by disruption of the normal balance between the corrosive effect of the gastric juice and the protective effect of the mucus on the gastric epithelial cells. In very simple terms, we can say that if there is the production of the acid, the acidic gastric juice in the stomach and the production of mucus, the mucus in the stomach are all balanced. The mucus is being produced and similarly the acidic gastric juice is also being produced in the stomach, and they are being produced in a balanced manner. Now consider a scenario where there is excessive secretion of the acidic gastric juice. Okay, in that when the acid is being secreted in very much excess and mucus production is normal. Okay, in that scenario also this excess acid can erode its path. It can erode this mucosal membrane and can further erode the deeper membranes or deeper layers of the stomach and the intestine. But this rarely happens, the excessive acidic production, this rarely happens. Generally what happens is the imbalance generally occurs where there is basically reduced production of the mucosa. Okay, when the mucus production generally reduces, now there is lack of sufficient amount of mucus to counterbalance this normally produced acid. Alright, the acidic gastric juice which is being produced at a normal pace, but mucus production has reduced, so it cannot counterbalance the acid production. So this is more common as compared to excessive acidic gastric juice secretion. Then another principal cause of peptic ulcer is Helicobacter pylori infection. Then Zollinger-Ellison syndrome also results in relapsing and recurrent peptic ulcer. I'll explain how. We'll begin, firstly we'll see the peptic ulcer due to Helicobacter pylori infection. Helicobacter pylori is a microorganism that invades, that resides in the stomach as well as in the intestine. It colonizes there. So what does this H. pylori infection does? It basically this microorganism it secretes urease. When it is living inside the stomach and the intestine, it does one thing, it produces urease enzyme. This urease enzyme breaks down urea to form toxic products, toxic compounds. Now these toxic compounds are not toxic to the microorganism Helicobacter pylori, but these toxic compounds are toxic to our gastric mucosal lining. Alright, so when they are toxic, they can result in the corrosion or erosion of this gastric mucosal lining, can harm the mucosa in the stomach and the intestine. This Helicobacter pylori also elaborates phospholipases and proteases. It also produces phospholipases and protease like enzymes. Now these enzymes can break down the glycoprotein lipid complexes in the gastric mucus. In the gastric mucosal lining, this gastric mucus that we talk about is basically made up of glycoprotein and lipid complexes. Now when the enzymes like phospholipases, the enzyme that can destruct lipids, and proteases, the enzyme that can destruct protein, are being produced by Helicobacter pylori, it can then result in the breakdown of this, it can result in breakdown of the mucosal lining, or it can result in the destruction of the mucus in the stomach and the intestine, thus damaging the gastric mucosal lining. Then H. pylori does not invade the tissue itself, but it induces intense inflammatory and immune response and resulting in increased production of pro-inflammatory cytokines from the mucosal epithelial cells such as interleukin 1, interleukin 6, interleukin 8 and tumor necrosis factor alpha. These further cause destruction and inflammation of the gastric epithelium. Now, it is the immune response. It is natural that whenever any microorganism or a foreign organism invades our body, the immune responses will be triggered inside our body. That's a natural response to any infection inside the body, right? So when H. pylori invades the stomach or the intestine, it also triggers an immune response inside our body. When an immune response is triggered, in that scenario, lot of pro-inflammatory mediators like interleukin 6, interleukin 8, tumor necrosis factor alpha, these type of mediators are released. Okay, these mediators basically, they not only harm H. pylori, their target is H. pylori, but they also result in the destruction of the gastric epithelial cells and the mucosal lining. Okay, so they basically result in the destruction of the gastric mucosal lining of the gastric epithelium, and they cause inflammation in the gastric epithelial lining, ultimately resulting in or worsening the ulceration. Also, H. pylori also enhances gastric acid secretion. It enhances gastric acid secretion, so it can worsen the conditions of peptic ulcer. It impairs bicarbonate production. Now, bicarbonate has the ability to quench H positive ions. So, it can balance the acidity of the acid being produced. Okay. So, now when H. pylori impairs bicarbonate production, so it ultimately reduces the luminal pH in the duodenum also. So, when the luminal pH in duodenum is also lowered, it further favors ulceration in the duodenum. H. pylori can go and because H. pylori requires low pH to survive, okay. So, it also enhances the low pH conditions in the duodenum, and there also it results in ulceration. Moving ahead to peptic ulcer due to NSAIDs and other medications. NSAIDs, or which we call non-steroidal anti-inflammatory drugs, and medications like corticosteroids, 5-fluorouracil. 5-fluorouracil is an anti-cancer drug. Basically, these drugs disrupt the normal balance between the corrosive effect of the gastric juice and the protective effect of the mucus on the gastric epithelial cells. Okay. Now, basically, their prostaglandins have a very important role to play in the production of the mucus inside the stomach. Okay. So, prostaglandin basically, prostaglandin I2, which is also known as prostacyclin, this enhances mucus and bicarbonate secretion from the gastric mucosal epithelial cells. So, in very simple terms, prostaglandin I2 or prostacyclin is responsible for enhanced secretion of mucus and bicarbonate ions in the stomach. As simple as that. This mucus attains gel-like consistency and then adheres to the mucosa, forming a film over it. Okay, so when this mucus attains a gel-like consistency, it thickens, alright, it is thick, and then it forms a film over, it forms a layer over the gastric epithelial cells, and then thus it protects it. So prostaglandins have a very important role to play. Now we know that, and also mucus traps the secreted bicarbonate ions and acts as a barrier for H positive ions in the gastric juice. Now what happens, we know that prostaglandins are produced from the arachidonic acid by the actions of the enzyme cyclooxygenase, COX-1 and COX-2. COX-1 basically has housekeeping functions. So when we consume non-steroidal anti-inflammatory drugs or other medications which can inhibit COX-1 functions, okay, so when this enzyme cyclooxygenase 1 is inhibited, the prostaglandin synthesis, the synthesis of prostaglandins from arachidonic acid is also inhibited. So when there is no prostaglandin, there is no PGI2, prostacyclin, so there will be reduced secretion of mucus, there will be reduced secretion of bicarbonate ion, and therefore when there is reduced secretion of mucus and bicarbonate ion, there is nothing, the mucus is not available or bicarbonate ions are not available for counterbalancing the acid production. So this acid can then corrode the gastric epithelial cells, the gastric epithelial lining. The other medications and even smoking and alcohol act as irritants of gastric mucosa and induce acidity. The people who resort to smoking or alcohol, in that scenario also, these act like irritants of the gastric mucosa that can ultimately result in acidity inside the stomach and can result in ulceration also. The third is peptic ulcer due to Zollinger-Ellison syndrome. Now what is Zollinger-Ellison syndrome? Zollinger-Ellison syndrome is basically the gastrin secreting tumors. So what happens in Zollinger-Ellison syndrome? Gastrin secreting tumors are formed. Okay, multiple gastrin secreting tumors are formed. Now when there is a tumor which is secreting gastrin, gastrin is what? It is a hormone. Okay, it is a hormone which by mediating histamine release, it promotes the release of histamine. Histamine then ultimately binds to H2 receptors which are present in the stomach. When it binds to the H2 receptors which are present in the stomach, it enhances gastric acid secretion from the gastric parietal cells. Okay, so now when there is a tumor which can secrete large amounts of gastrin, that means that this large amount of gastrin will again trigger, it will stimulate large histamine release. This histamine will bind again and again repeatedly to H2 receptors in the stomach and will increase the secretion of acid in the stomach. Hence, Zollinger-Ellison syndrome results in gastric acid hypersecretory state. There is hypersecretion of gastric acid which induces refractory peptic ulcer, which means that there are repeatedly and large number of peptic ulcers are formed. So there is refractory peptic ulcer, large number of peptic ulcers are produced. Now coming to the symptoms of peptic ulcer. The major symptom of peptic ulcer, how a person can detect it or know about it, is the epigastric pain. When I use the term epigastric pain, I am talking about the pain in the upper abdominal area, just below the diaphragm, or you can say just below the ribs, alright, in the upper abdomen. Now, if the pain occurs immediately after 15 to 30 minutes of consuming food, it suggests that the ulcer is present in the stomach region. When the pain occurs after 2 to 3 hours of consuming meal, it suggests that the ulcer is present in the duodenal region. There is a duodenal ulcer. Then the other symptoms of peptic ulcer are heartburn, Heartburn is basically reflux of the gastric content. Now when I say gastric content, it also contains acid. So when the acid will be refluxed to the esophagus, it will damage the tissue in the esophagus also, and it will result in pain, which is known as heartburn. Then bloating, which is gasiness, abdominal fullness, nausea and vomiting are also very common in case of peptic ulcer. There is excessive weight loss in peptic ulcer because of progressive dysphagia. Progressive dysphagia means there is reduced hunger, we can say. The people eat less, and this ultimately results in weight loss. Progressive dysphagia and weight loss. So this is all about the pathophysiology of gastrointestinal disease, peptic ulcer. Thank you.